afternoon to everybody. Thanks to everybody who's here in person, as well as those folks who are online. So we're holding this panel so you can hear firsthand from some of the leading health authorities in our county on the latest trends for immunizations and vaccines and how that is affecting the health of our community. This conversation first started, I was reflecting more on that today when I was thinking about what I was going to say. Back around April, whenever some of you might remember the news stories coming out of Louisiana and Idaho, where local boards of health, or even actually may have been at the state level of Louisiana, started to disallow health departments from providing COVID vaccines or promoting COVID vaccines. And this was very concerning. And shortly thereafter, actually, Ben Franklin here in Eastern Washington started to head down that path. So there was a concern about that, pretty widespread, and it actually resulted in House Bill 1351, which I don't know if everyone's familiar with, that passed during this last session of our state legislature, which ensures that local and state health departments, regardless of any intervention from boards of health or other local government, can enact evidence-based interventions for the preservation of public health. So that is great, although sad that needs to exist, but I'm really glad that we took that step here in Washington. And whenever all of this was happening, our previous director, Dennis Horsham, who now is the Secretary of Health here in Washington, had this idea. And so I took it and said I would take it on and make it happen. It took a long time, but we're here. So thanks to the panel for being here today. With the idea that, we wanted to diffuse the conversation and the leadership on this topic throughout the community, and including, community leaders like the folks we have here today that I'll tell you a little bit more about in a minute, that we know are really trusted by the patients that come to see them and their organizations. Unfortunately, public health in and of itself and immunizations themselves have become politicized significantly since the pandemic. And, it was already happening to some degree prior to that, with the kind of culmination recently of this being the shooting we saw at CDC last Friday. So as well as the enactment of the policies I mentioned earlier, away from, championing scientific evidence and evidence-based medicine and practice of public health as well as medical delivery. So as well as the changing federal guidance and funding changes. So what has commonly been referred to also as mis and disinformation has been kind of is becoming more and more common over the last several months. And this will hopefully help combat that. But also I want to start using the word rumors instead of mis and disinformation to also try and help depoliticize that conversation. So as you can imagine, using the word mis and disinformation has some combative connotations to it. It's accusing someone of purposefully saying something incorrect, whenever it's very possible that people can have misconceptions about things that they've learned from people they trust, who, have a belief for whatever reason and share that belief. And we've all probably, I know I have been, have done that in my life. And so using the word rumor hopefully gets us closer to a meaningful conversation about these issues that are coming up. So public health is a cooperative venture, as we just learned about from the Community Navigator program, which was very successful. And we need community leaders to join us in addressing the problems of our community that our community is facing. And to that end, we have the following panelists who are joining us for today's conversation. If we can go to the next slide. So Dr. John Dunn, who is the Medical Director of Preventive Care at Kaiser Permanente, although that may be changing shortly. I'll let him talk to you about that. And he's going to talk about navigating federal changes to vaccine guidance. And then we have Dr. Cornelius Van Meel, who's the Clinical Director of Pediatrics for CMAR Community Health Centers. And he's going to talk about effective strategies for promoting vaccines in clinical settings. We have Dr. Catherine Lee, Medical Director for Western Washington Medical Group, who's going to talk about following immunization coverage and public health impact. And then Dr. Jay Cook, who's the former Chief Medical Officer for Providence Regional Medical Center here in Everett, and who's going to talk about low vaccination rates and how they can strain the healthcare system. And then myself, who's the health officer here at Snohomish County Health Department, who will moderate the discussion. And to provide some additional context for this discussion, if we can go to the next slide, I just want to show you some data about what's happening with immunizations. So this is state level data that was obtained from the CDC's website showing various immunizations. But if you pay attention to that light purple or lavender line, that represents MMR. And you can see across Washington, we've been heading in the wrong direction for MMR coverage over time. Next slide gives you a more local look here, just Snohomish County data that our EPI team has pulled. So thanks to them for getting the slide for us. If you look at that bottom line, that's overall immunization rates for all of those different diseases that we see at the bottom, including measles, as well as a number of others. And all of them are declining over the past 5 years, unfortunately. And so what does this mean? If you go to the next slide, now we'll look at national measles trends. So while it's not a straight line where every year there's more and more measles cases, you can definitely see if you adapted a straight line that kind of averaged out the number of measles cases over the last, almost 30 years. We're seeing an increasing trend with this most recent year or our current year being the highest number of cases we've seen in more than 30 years, which is definitely concerning. And then if you go to the next slide, we'll just give a context of all of the headlines we've been seeing around this, around all the federal policy changes we're seeing, the shooting at CDC, the kind of defunding of mRNA vaccine research, and just really how this this conversation is developing. So we're going to have a fifth panelist today, who is Chelsea Charles, but she was unable to make it due to some childcare requirements. And she's a Snohomish County resident who sadly lost a child to pertussis, a completely vaccine-proof disease, more than a decade ago. Unfortunately, she couldn't make it, but we have permission to share her story that was highlighted in a recent Seattle Times article. And I'll do that at the end of all of our panelists providing their comments. And then after that, we'll go into a Q&A with the board here and potentially a couple of questions from staff members of the health department as well. So with that, I'll go ahead and hand it off to Dr. Dutt to get us started.
Hey, thank you very much for having me and thanks for your attention. Things related to immunization are sort of a long-running concern of mine. I've been a pediatrician practicing in the state for 25 years. For most of that time, I practiced right on the King County, Snohomish County line. So really the majority of patients that I've seen over the course of my career are your charges here. I've also had a chance to be knee deep in all things vaccine, both in my recently ended role at Kaiser Permanente and serving on advisory committees both at the state and federal level. So I've gotten to see this from all sides of the table. I don't want to get very wonky about this. I'm perfectly capable of talking for hours and really boring the hell out of you. I do want to start with a very high level overview of this and discuss a little bit alphabet soup, because I know that both folks who are attending and the folks on board come from a lot of backgrounds. You've read in the paper and heard about ACIP and the FDA and the CDC and everything. Let me start by giving you a quick run through the alphabet soup, okay? Where immunizations are concerned, the two big important entities are the Food and Drug Administration, the FDA, and the CDC, Centers for Disease Control. Each of them has an independent advisory committee. The one you keep hearing about called PERPAC. I'm not going to spell that out, is the one that advises the Food and Drug Administration. ACIP is the one that advises the CDC. Ultimately, though, it's those agencies that think they're the ones that issue recommendations, guidance, or approval. People often get confused about the difference. The way I've simply explained this to people in the past is that the FDA gives permission to do things. The CDC gives guidance. Keep that as your mantra. So you'll hear me talk a lot more about the CDC because that's where our current biggest problems lie right now. The role of the FDA is to determine whether something is safe and effective. I often hear people ask about, well, shouldn't we just follow FDA guidance? Shouldn't we just follow what's published in there? And that shows a fundamental misconception. The FDA does not, never has given guidance about anything. Yeah. They allow a manufacturer or company to market something, and they say what they're allowed to say when they market it. But they don't say anything about exactly how it can be used. And the truth is that in practice, we do things outside of what the FDA says. That's, I guess, to be background, if any of you have known young kids with asthma, they've been treated with something called albuterol, which is really the only thing for an acute asthma attack at that age. The FDA doesn't actually say you can use that under 4 years of age. I've been doing that for 30 years, and there's unbelievable amounts of evidence that says it's safe and effective to do so. But that's not FDA guidance because the FDA doesn't give it. The CDC, based on recommendations from the ACIP, does give guidance. The third body are not government. They are all independent volunteers. They are experts with very bad backgrounds and expertise. They are not paid. They're screened heavily for conflicts of interest. The great concern that the medical community and the public health community and public at large has had is that with the new administration, in part, the people with that expertise have been removed from ACIP. They were removed wholesale, and a bunch of people were put in who didn't necessarily have the same background or expertise, and some of whom were openly anti-vaccine. Does that concern me? Yes, but not nearly as much as certain other elements. The truth is that anybody who is dedicated to looking at evidence and pursuing it, whether or not they've got a background in it, and whether or not they have a particular opinion, should be able to arrive at an appropriate, evidence-based, scientifically founded answer for something. And the great concern that's coming up is that that is what has been compromised. At the most recent ACIP meeting, for example, there was a work group that had been trying to put together recommendations on what to do about COVID vaccines for the fall. That work group was disassembled prior to the meeting. And a recommendation was made that involved no input from the advisory committee at all. A second vote was taken on another subject that also did not involve a work group or input from an advisory committee. And the greatest concern that we have about that, I didn't particularly agree with either of the recommendations that were made, but often recommendations have come out of ACIP, and I wonder, why didn't they recommend such and such, or what are they thinking about that? And I've always had my answer available, because anytime the ACIP recommends something, they use a very heavily structured evidence review process and evidence to recommendation process that they go through publicly in the meeting that gets published, and then the whole thing gets published in a document anywhere from 10 to 40 pages long that gives me more information than I could possibly want to know, along with a couple hundred references, all of which are publicly available. In short, I can find out exactly why it was made, why that recommendation was made. And at the end of the steeplechase, I'm afraid I have to agree with it, because it's hard to argue with work done that way. The new recommendations don't involve that sort of evidence. And they don't involve that sort of transparency, despite what's ostensibly a push for greater transparency. That's the great concern most of us have. Again, I have I don't have much concern with who's on those committees. I don't even have concerns with the answers. As a guy who does evidence review for a living, often I don't get the answer I want to find. That's the nature of that game, and that doesn't bother me. It does bother me when it's not blatantly transparent why a decision is being arrived at. The great concern from your standpoint is how that's going to impact access and coverage for vaccines. Because there's great concern that the guidance is no longer based on science, and there's concern that more changes in the vaccine schedule will occur in the future. All of a sudden, nationally, there's no longer a consensus that ACIP recommendations are the ones that we all should follow. Up to this point, for the last 15 to 20 years, there has been a general consensus among stakeholders and medical organizations that we were all going to throw in with that, because the process was transparent, it was impeccable, and we could rely on those results. Now that we can, it's not entirely clear a year from now what sort of recommendations are going to exist or whose advice we should be following. And at the immediate moment, there's not there's not yet some organization waiting in the wings to be able to do this work that was previously done by the ACIP. And the upshot of that is that we may find ourselves very soon in a situation where recommendations can vary from state to state, even potentially from county to county in states, and where people who don't live in this space all the time, the way folks like me do, all of a sudden cannot find a single source of truth, where they're not entirely sure what the right thing to do is. The impact that will have on coverage boils down to this. Many organizations, many departments, for example, Vaccines for Children, which has been alluded to, Vaccines for Children is the state level process that covers vaccines for uninsured, underinsured, Medicaid eligible, in addition to American Indian, Alaskan Native. In a place like Washington, that's about 50% of the kids, okay, in the United States. And the way that their charter is written, they only cover things that are ACIP recommended, which means if all of a sudden the ACIP stops recommending certain vaccines, that's not going to be covered necessarily. And should that happen, that of course is going to impact precisely the people who cannot afford to have impacted. It's going to impact those who won't have private insurance and who will at least be able to work around this voluntarily. For others, for people who are insured, as of right now, the Affordable Care Act not only says that the vaccines need to be covered for the vaccines recommended by ACIP should not only be covered if they're routine, but also if they're covered on a shared decision-making basis. At the moment, it looks as though coverage by private insurance plans for most things would still be mandated under ACIP, provided that somebody asks for it, if they're privately insured. That situation may not be true down the road. The universal funding mechanism for vaccines in Washington State through the Washington Vaccine Association at the moment adheres closely to ACIP, and there's a question about whether that's appropriate. My global advice, because my topic was how to navigate this, my global advice is twofold, which is stay tuned and be nimble. A lot of things are going to happen. They are all going to happen very fast, and we need to be prepared to make adjustments on the fly that in your line of work and my line of work, we're not generally used to.
Well, thank you, Dr. John. That was very informative. And to put a local spin on the ACIP issues, there is a local doctor, Dr. Helen. She was supposed to be on the ACIP and got let go before her first meeting. She's a research scientist in infectious disease at University of Washington.
Sure.
So yeah, it's a very unfortunate situation. We'll talk more about that, I'm sure, with questions later, but we'll move on now to Dr. Cornelius Van Niel, who will, from CMARC, who will talk to us about effective strategies for promoting vaccines.
Thanks. Thanks, James. Thanks to the board for inviting us. So I am a primary care pediatrician. I work at CMARC clinics in Seattle and in Marysville. And I have done so for the last 24 years. And I do what I do because of the families I work with, the relationships that I experience in my work. And when I think about vaccines, I think about the role that we play for families in general as primary care providers. We're allies. We obviously want the same thing as the parents of children want. That is the best health and well-being for their children. So that's a great starting point to have when you're talking about vaccine discussions. The way I approach vaccine discussions in clinic is to make a strong recommendation that, and I come from the presumptive format approach, which means I say your child is due for vaccines today. And I'm assuming that the family is going to go with that, and that'll be what happens in the clinic. And in my experience, having discussions with families where we are downloading evidence and rebutting reasons that parents may have for not wanting to do vaccines is really not very helpful and can be adversarial. So I think, coming from a collaborative perspective is what works best in clinic. Using motivational interviewing can be helpful, leveraging reasons that parents might have for giving vaccines. And that having a partnership with families, coming from a place of curiosity, asking for permission to offer my perspective, and acknowledging concerns genuinely, I think are the best ways to promote vaccination in clinic. Sometimes, after discussions, or if I know a family quite well, I might address hesitancy with some strategies, for example, prioritizing vaccines. So families may not want to give a large number of vaccines, but I will say, well, I'm really concerned that your child would be at risk from measles, pertussis, pneumococcus, polio. Maybe I'm not as worried about for your kid, so maybe some prioritization. But I think that's kind of a later discussion. I think first is to make a strong recommendation, vaccinations. And I know we're talking about county level, state level efforts to promote vaccines, but I want to talk about just the clinic level. And I think having a clinic-wide plan in our clinics, and it may be individual clinic to clinic, but in our clinic, what we do is have everyone on the same page. So we talk as a provider group, talk about what our perspectives are and what our goals are and what our pressures are when we're talking about vaccines with families. We also involve all our staff in our clinic. So the nursing staff, the front desk staff, so that we all have the same message that a child is due for vaccines that day. And that we're all kind of using the same messaging, same process from the front desk. And there could be, certain processes that are very helpful with this, having standing orders, allowing vaccines to be given at nurse visits if the provider visit is not available for a family, for a child. And another thing that we do in our clinic that's pretty common is to use vaccine opportunities. So a child comes in for a sprained ankle or for a cold, and they're due for a vaccine. My families are kind of trained that they know this. They know that their vaccine record will be looked at every time they come into clinic. If they're due for something, we'll say you're due for a vaccine, regardless of the reason for the visit, and then they'll be vaccinated. So I think that's another really good way to improve vaccination rates is to use every vaccine opportunity that we have. And a good recent example of this that's new is young babies who are getting RSV immunization soon after birth, if their pregnant parents haven't received it during pregnancy. They get it, as early as birth. And so when babies come in for checkups for jaundice or weight gain, that's an opportunity to use this immunization. So that's just one recent example that's new for us. We also do other kind of systems strategies where we'll reminders for influenza vaccine to all patients with asthma, for example. And you kind of utilize other ways to get people in to the clinic for vaccines, and then when they do come in and be consistent about how we promote them. I want to touch on vaccine exemptions for a little bit, and vaccine exemptions are available by law in Washington State for the vaccines that are required for schools and for childcare. And this is another area where consistency in our approach is really important, and the messaging is really key. So our approach, we do offer appointments for vaccine exemption form signing and discussions. We like it to be an in-person visit. That's not stipulated by law, but I think that the kind of spirit of the law to have that mandates a discussion that goes over risks and benefits is best done in person. If it's a new patient to our clinic that we don't know, we ask them to establish care at our clinic and have a well child check as part of that visit. We're not taking people just for appointments for vaccine exemptions if they're not already our patients. We have a risk benefit discussion, and I think it's good to all be on the same page as colleagues in our clinic as well, and educate each other about what we talk about it in risk benefit discussions, and also to know that when we as healthcare providers are signing those forms, we're not agreeing with the family's reasons for an exemption. We're just saying and documenting that we had a risk benefit discussion with the families about vaccines. And also the other thing to talk about as a group and to be knowledgeable about is the various types of exemptions. So what is the difference between religious exemption and a religious membership exemption, which are two very different things under the law. So we, and then another thing that we do in our clinic, or at least I do, my style is to say, okay, I've signed your exemption form, but next time you come in to see me, we'll talk about vaccines again. So that's kind of, it's going to be an ongoing discussion with families at future appointments. And I also will mention things like, a child who has a vaccine exemption may be excluded from from a school or daycare in the event of an outbreak. So make the families aware of that. There are providers in Washington State who refuse to sign exemption forms, and that's a choice that providers have. I don't have that choice in my practice. I feel like making that choice makes it impossible for us to influence families later about vaccinating kids. And also it makes it hard for us to care for their children in other ways. So I think engagement is better than refusing. I just also wanted to mention childhood vaccination program in Washington so that all kids can get vaccinated regardless of insurance coverage or financial situation. Fortunately, the COVID vaccine, which has been changed to a shared decision-making recommendation, is still covered because under that designation. So yeah, I just want to come back around to the fact that as a primary care pediatrician, I see how essential and wonderful it is when kids have a medical home, a healthcare home. And this needs to be available to all kids and all families. And when this is in danger, this is where we need to advocate as well, to make sure that kids of all socioeconomic backgrounds have access to health homes. And when this happens, we can have relationships and trust with families. And these relationships and trust that we build are what will promote vaccination.
Great, thank you, Dr. Vidnell. That was good advice. And I realized I hadn't said anything, but I think it works well. Our immunizations team, our recently reinvigorated clinical immunizations team is here. They hopefully will use a lot of that. I had some nodding along, so I think you're saying a lot of things they already agree with, but it'll be good to reinforce, and then we can share that also with the providers we work with. So we'll now move on to Dr. Yee, who's going to talk to us, and she's from Western Washington Medical Group, and will talk to us about following immunization coverage and public health impacts.
Okay, so Dr. Catherine Yee, by background, I'm actually an interventional pain physiatrist. So I take care of patients of various ages, and I look to reduce disability and enhance functionality. And as in my practice, I know there's a lot that can be prevented. And so while I try to address the back end of things, I have these ongoing relationships with patients where we can start saying, hey, maybe we should look at the front end a little bit more, or there are some opportunities where we could really make a big impact, not only for you going forward, but maybe even for your loved ones who you might actually have some influence around and have these conversations. So in my practice, I've really enjoyed having, establishing these long-term relationships with individuals, my patients and their families. And a lot of times the discussion around vaccination and other prevention strategies becomes part of our appointments. Just on the topic of falling immunization rates and public health impact, I get the sense that people have a pretty good feel for what happens when we fail to prevent things that are preventable. It's important to reach herd immunity percentage of vaccination in the population so that we can help to keep safe individuals who may not be good candidates for vaccination. Reaching a certain percentage of immunization is important from a population standpoint. On the individual standpoint and from the employment standpoint, we of course want to help prevent absenteeism. We want to keep people at work. We want to have them continue to be functional members of society. People also want to be functional members in their own lives, and so I find that framing up the conversation around vaccination that way really hits home in a different way than saying, "Hey, I need you to do this because it's required." I love that there are conversations really structured in practices that say, "Hey, this is the norm. This is how we talk about this. Expect this conversation." I also find that for individuals that might say, hey, you know what, I really want to have a more nuanced conversation around this. What are the benefits to me? What are the benefits to my family and other things that I care about? I think it's important that we, as we have these conversations with our patients, that we're looking at it from their perspective, from their vantage point. And in many ways, giving them, this is like a little bit of a parenting phrase that I've learned, most generous interpretation, right? Dr. Becky, right? That's the idea that we give, that we lend to others, and the most, I guess, the most generous interpretation of what they're aiming to be. And we want to say, hey, you're coming from a really genuine place where they also care deeply about their children, about their families, about their loved ones, about their multi-generational households and contacts. And starting from that space, I think, is really productive and very fertile. And when I come to see my patients in pain practices, I think about that as well. I like to assume that patients are coming to see me because they really want to get better, that they didn't become an opioid addict because their parents raised them that way. Nobody does that, right? Nobody does that. And I think it's important to make sure that we're coming at these discussions from that really genuine place. It takes a lot of energy to do that. And I think it's challenging in this atmosphere, in this situation where the discussion around vaccination, around immunization, around what does public health look like, has really put a lot of burden on our clinicians to say, oh my goodness, I need to structure these conversations. I need to make sure that these are that I'm addressing every individual as an individual every single time. It's a lot of work. It's a lot of work. It's important work, but it's a lot of work when these norms and change. When I asked the question earlier about our community health navigators and their ages, what I was getting at there, thank you for sharing that your community navigators are such a wide range of individuals. One of the things that's important in the conversation, I think, is to realize who is your audience, right? We know that vaccination tends to protect individuals from acute disease who are in the older decades. For an individual who's, say, a Generation Z, that individual, may not have that same protection, may not have that same personal protection because maybe they're generally healthier. However, if you come at that Gen Z individual and say, hey, listen, you are living in a multi-generational household where you have somebody who is in another decade who you also want to protect, and maybe that's something you care about, maybe that's the reason to encourage to encourage them to get vaccinated. Another thing that I think we'll see outside of not just the upper respiratory preventable illnesses are, putting on my hat as a pain doc, are other preventable pain conditions. So an example that I have is when I talk to patients about, if I see them for a painful condition, I might say, hey, by the way, are you up to date on your pertussis vaccine? And they might say, oh my gosh, why are we talking about pertussis in a back pain clinic? And it's because I've actually seen patients who've suffered from whooping cough and fractured their backs and blown out discs. I'd love to prevent you from having that. Let's get you updated. It's such it's such a change up for them. But another one that I think is another example, is the shingles vaccine. Shingles is it's not only a painful condition, but it's a very difficult condition to treat if a person is unfortunate enough to have chronic pain after. The post-herpetic neuralgia condition is extraordinarily difficult, and it's one of those conditions where you'd love to have prevented it, could have in the first place. So for my patients who might be, reluctant or thoughtful about it, or not super excited about the idea that one's gonna hurt like the devil, we might say, hey, listen, we need to have a real sit down and talk about how we can prevent you from having to see somebody like me again. Right? There are other benefits. There's a study that recently came out about the shingles vaccine helping to reduce or prevent or reduce the prevalence of dementias. So I've got a number of patients who are really mindful about their brain health. Can we start these conversations in other settings? To help with to help make sure that we're supporting our primary care docs in their very important messaging. So falling immunization rates certainly have a big impact on our community's health. They certainly have a big impact on public health. There are lots of repercussions to outside of just the absenteeism, just being able to prevent illness, just to keep kids in school. There are a lot of really important things that come from vaccination campaigns that may be just as important to our patients and our community and are very worthy of discussions. Thank you for your time and for letting me speak to you about my passion.
Thanks, Dr. Yee. I really love the framing of it in terms of, pain conditions or other chronic conditions that people can have, and then tying those two vaccines. Another big one would be, HPV vaccine and cervical cancer. I feel like that doesn't get highlighted enough, so thanks for sharing. Also, I meant to share earlier, you have another claim to fame, which was you were a medical advisor or took part in the show Second Opinion with Joan London on PBS for 13 seasons, so that's pretty cool. Good celebrity. And so our last panelist today is Dr. Jake Cook. He's from, was recently the CMO for Rob Everett here, and he's going to talk to impacts of the medical system.
Great, thanks, Dr. Lewis. I'm really honored to be here with these amazing clinicians and leaders, and appreciate the time you've given me to briefly talk with you about this. So, full disclosure, I'm not an epidemiologist. I'm not an infectious disease specialist. I did practice surgery here in Everett for over 25 years until 2017, where I became chief medical officer of the hospitals. And one of the things I did in that role was I helped lead all of the clinical teams that provided care in the emergency department, patient units, and intensive care units. And that included the time from the time we here in Everett cared for the first COVID patient in the United States in January 2020 until 2023 when I retired. So I was there, during the worst part of the pandemic, and I feel like I saw, firsthand and up close how care was delivered to thousands, literally thousands, perhaps tens of thousands when we count the emergency department visits of patients with COVID in our community and region. For some context, there were, I believe I saw this on the website here, there were over 200,000 patients in Snohomish County who had COVID, and there were about 1,500 died from COVID. Many of those were in the hospital. And this experience, plus my reading of dozens, if not hundreds, of peer-reviewed, carefully done scientific studies from multiple institutions around the world, led me to firmly believe that the COVID vaccines, including the ones that were made with mRNA technology, saved hundreds, if not thousands of lives just here in Snohomish County. So I'm a firm believer, full disclosure. I've never taken any funding from any drug company. And I do share some concerns that people have voiced about the potential and the appearance of conflict of interest with certain drugs and vaccines. I mean, I think that is a valid concern, but I think that there are structures, there have historically been structures in place, as Dr. Dunn and others have mentioned, that carefully look at this. And I believe that our vaccine record over the years has, really been a huge success story. And just like Dr. Yee, I come at this with the assumption, and I truly believe this in my heart of hearts, that everyone wants to keep themselves safe and their loved ones safe. And I think everyone here, and particularly the Board of Health and the County Council, are concerned also very deeply about the health of the whole community, the whole population. And so with that as background, I want to make sure everybody understands that if the vaccine rate continues to increase, there will be a predictable increase in both the frequency and severity of disease outbreaks for conditions that have historically been deemed, successfully eradicated. And so, I think that we can take measles as an example. It's been alluded to a little bit, but since in the 21st century, since 2000, there have been an average of about 200 measles cases per year in the United States. And in 11 of those years, there have been less than 100 cases. And those are sporadic. People travel and visit places and bring it back, or there have been little outbreaks in communities that, were unvaccinated or not vaccinated. But so far, just as of last week, there have been over 1,300 cases of measles reported in the United States in 41 states. And we're barely halfway through the year. So this is on track to be enormously impactful this year. And about 95% of the cases so far have occurred in people who are either unvaccinated or incompletely vaccinated. And probably, well, not probably, 2/3 of patients with measles this year are children, pediatric age group. And about 20% of younger kids, less than 5 years old, have required hospitalization because of measles. Now, some of you may know that for the past 2.5 years, we have had no inpatient hospital beds for pediatric patients in Snohomish County. There are also no pediatric inpatient beds in Skagit County or Island. All of the other pediatric inpatient units are under great constraints, both operationally and financially. And, our healthcare system will be severely challenged if we have significant outbreaks of highly communicable diseases that, like measles, that a large percentage require hospitalization. It would be particularly tragic in the case of measles, because we know that with proper immunization, complete immunization, it's 97% preventable. So that would be a tragedy of a high magnitude. And another thing that is impacting our ability to manage a severe outbreak of communicable disease that's been alluded to a little bit here is the fact that a large percentage of children living in Snohomish County have their healthcare coverage through Medicaid or the Children's Hospital Insurance Program. And as you know, those programs the funding is being cut, for lack of a better word. And so that's a challenge to both the individual families whose children will be impacted by this, and frankly, the healthcare system, which most hospitals really haven't fully recovered from the COVID pandemic from an operational or financial standpoint. And trying to kind of determine what it might look like looking in the future if vaccination rates continue to decrease nationwide. There was a group of researchers from Stanford and a number of institutions across the state of Texas recently reported a study that was just published last month. And their data showed that just if the levels of vaccination for measles just stay like they are now, then there's a 3 in 4 chance, a 75% chance that measles will become endemic in this country, like it was pre-2000. And the estimate is, there's a range of estimates, but the kind of average estimate would be 34,000 new cases of measles a year. And that's compared with 200 cases a year for the last 25 years. They estimated that if there's a further 10% decline in vaccination rates, that number of measles cases, I'm going to read this because it's important, goes up to about 400,000 new cases of measles a year. And in the worst case scenario, if all childhood immunization rates decrease by 50%, which sounds crazy, but I don't think that is completely outside the realm of possibility. And I'm going to read here again, an annual rate of over 2 million measles cases, 800,000 rubella cases, and over 350,000 new polio cases. How many? 350,000 polio. 10 million people hospitalized, 150,000 die, 5,000 new cases of paralysis from polio. It's mind-boggling. And as others, Dr. Yee and others pointed out, it's not just children who suffer from these diseases. You know, the main kind of categories of folks who are very sensitive to infectious disease that either can't be vaccinated successfully or have a high risk of being vaccinated, are newborns, the elderly, and immunocompromised folks. All of these groups are very vulnerable if the prevalence of disease increases significantly throughout the entire population. If that were to happen, then it wouldn't just be a problem for pediatric hospitals, it would be a problem for all of the hospitals in general. And more sort of statistics that are sobering to me is that Washington State currently has the lowest number of inpatient hospital beds per capita in the country, number 50. And Snohomish County ranks among the lowest within the state of Washington. Snohomish County has 40% fewer inpatient beds per capita than King County, 33% lower per capita than Pierce County, and over 50% lower per capita than Spokane. So this is a real challenge, particularly for diseases that can be prevented successfully, say effective vaccines. The other piece of the picture is that sick adults who come to the hospital are going to need post-acute care at a skilled nursing facility. Again, Snohomish County is not in a good position here. Snohomish County has less than half of the skilled nursing beds per capita that are recommended by the Department of Health. And so those institutions exist, those existing hospitals and skilled nursing facilities are also going to be negatively impacted by Medicaid that we all expect or to reflect the most recent legislation. So, I think that to summarize all this, I think it's vitally important for individuals, families, and communities to keep a lid on these diseases that can be prevented or minimized by safe and effective vaccines. And it's also in all of this, it's important to recognize that the vast majority of Americans still support vaccine. This is not something that, it gets a lot of press, but most people still support requiring vaccines before getting to school. So we just need to convince a critical number of people, but not everybody about this. And I think it's also important for healthcare professionals like us, but like all, to work very carefully with our elected officials and our other community leaders to help build the public trust back with vaccinations and this preventative care. And I think that having these kind of conversations like we're having today is a really good step in that direction. So I really appreciate the opportunity here, and I'll be happy to answer whatever questions.
Well, thank you so much, Dr. Cook. Let's give a round of applause for the. I do want to just wrap it up, talking about 10 million people getting preventable diseases can be, you can kind of lose yourself in the numbers. So we can tie it back, if you'll pull up that last slide, or second to last slide, not the thank you one. I just want to talk about Chelsea Charles's experience from the Seattle Times article. So you can Google it there. It's from July 8th, this past month. So Chelsea's daughter, Kalia Jeffrey, died from whooping cough or pertussis at just 27 days old. Too young to be vaccinated, but exposed to someone presumably who likely could have been vaccinated. Kalia's symptoms escalated rapidly, leading to life support and ultimately death, leaving Chelsea in shock and denial. Important context for this was it was 14 years ago, and at the time of her birth, the DTaP or the pertussis, diphtheria, and tetanus vaccine during pregnancy was not yet recommended. The CDC began recommending that maternal pertussis vaccine a year after Kalia's death. Too late for her, but a standard of practice now that unfortunately is falling in uptake, as we mentioned earlier. Chelsea now has 3 kids, and she made sure to get vaccinated during pregnancy for all 3 of those subsequent pregnancies to protect her youngest children. Her story is a stark reminder of the real life consequences of vaccine gaps, especially for newborns. And despite her loss, she continues to be a voice for public health and prevention, especially amid rising vaccine hesitancy. So she wanted us to share her story today, even though she could not be here in person because she was taking care of her kids, which is very important. Another kind of note around data, just around that, about 72.7% of 19 to 35-month-old children were vaccinated statewide in 2016. And that has fallen even further in 2024 to 65.4%. So we're really heading in the wrong direction. And it's very likely we'll see situations like Kalia's happen again if we don't turn it around. And I'll just say, I think what I heard from all the panelists is we all want to come at this together cooperatively, and we want to establish trust and re-teach the community why they should trust us. And some people here already have great trust in the patients that they work with, the communities they work with on a regular basis. So let's expand on that, and let's take some questions.
Help me with, especially that are educating moms, dads, bringing kids in. I don't want to risk a vaccine injury, so I'm going to not vaccinate my kid, contributing to the population that could injure my kid. Right? I'm struggling with, what do you say to a mom, a dad who needs help, understanding that you really don't want to mess with these odds? The 10 million, the no beds, the no sniff beds, how do you handle that?
I think just reiterating this, that vaccines are safe. They're incredibly safe, and they've helped remove these terrible diseases from our society in large part, and not try and come at it with logic
Okay.
necessarily about the risk of one approach and benefit versus the benefit of another approach, or data specifically about safety. No vaccine is 100% safe. No vaccine is 100% effective. Those are facts, just like any other medical intervention. So I feel like reiterating how important they are for your child's health. I strongly recommend the primary care pediatrician, and they're safe. To my children, sometimes that carries a lot of weight as well. That's, I think, just having a direct, simple statement like that would be the first way that I would try to.
What are the top couple of reasons that parents give for being concerned about vaccines? Is it autism? Is it, I don't even know what the other ones are. I wonder.
Sure, yeah, I mean, a lot of them, might classify as reverse or that's.
Yeah.
Too many vaccines. Why are there so many vaccines? So many antigens now, is that a concern? There are preservatives in vaccines. Talk about what most preservatives have been removed from vaccines. That's not it's a big concern and those preservatives make vaccines safe. And they are safe. And the amount of aluminum that you receive in a vaccine compared to the amount of aluminum you receive in your food, in your baby food. It's not comparable. So you can get into debates like that, but I guess one message I would have is those aren't worthwhile, in my experience.
Okay.
But yeah, those are kind of the top concerns that I hear.
Preservatives.
Something else that you said earlier, that's, or you were something similar that I always make sure to remind myself and remind your parents is when I start these conversations, at some point along the way, I always work in a phrase to the effect of, look, I know the reason you're asking me this is because you want what's best for your child. I want that same thing. It's helpful to remind them and to remind yourself that we're all on the same side of the table. And it's something that took me a long time to learn. I used to be good about browbeating people about this, and that's partly ineffective and inappropriate. Something that took me a long time to learn is that this is a long game. That it's, they want to know that you know what you're about. They want to know that you're a person about it, that you have stats, that you have data, but ultimately, this is a decision. This isn't a decision that necessarily is going to involve logic. It is going to involve it's going to involve feeling deeply inside, and the advice you're going to take from a trusted circle of insiders who they feel really have their child's best interest at heart. Ultimately, with people who are in their job, is to try to become part of that trusted circle. That is generally something that's not going to get someone vaccinated that same day. Often where I've been most effective, people have wanted to talk about it. They have wanted to have these debates and things, and often they don't. I agree, big numbers and the like. It's important for me to know so that I truly believe what I'm doing. But ultimately, at the end of it, I will usually tell people, look, I know that we've just had a lot of this done decision now. Hey, don't drop the subject. I'll set up sometime, well, let's talk again. And over time, that all changes. It doesn't change for everybody. And you need to meet people where you are. You really underscored that as well, which is, I don't have to get everything.
Validating the concern, saying,
I think
it's your decision. This is a big decision.
Yeah.
What you saw on the internet,
Mhm.
it sounds like it was really concerning to you. Where they're at. Be helpful, collaborate.
I have one kind of add-on question to that. I hear like the idea that it's not necessarily a situation where you want to try to logic somebody into inclusion. But I wonder what I would be tempted to do, and I do in my personal life all the time, would be to use, and I have done for vaccine conversations, is to use an example to try and illustrate how you take similar risks to prevent worse things all the time in your life. But one possible analogy to use is seatbelts, right? Like there's a theoretical chance that wearing your seatbelt could be the reason you die in a car accident, but there's a much greater chance that the seatbelt's going to save you in a car accident. I'm curious if you ever use this thing like that, or if you think that wouldn't necessarily be effective in this type of conversation.
I'll chip in. I think it depends. I think it depends. It depends on the person, the family to whom I'm talking, and it depends on exactly where they're coming from. That's part of the reason this is a long game, I think, is that you need to know someone well enough to understand what will happen purchase with them. But I've done things similar. I have that seatbelt that never occurred to me. That's way better. So I'll give credit where credit is due, right? That underscores part of the challenge here, which is that in my job and in your position here, our tendency is to think in terms of populations, big things that we can do, and really the most of the success that I've had has been one family at a time. And there aren't enough soldiers in the world to do that. And so that's the great challenge, is figuring out how to manage.
I think from the long game perspective too, knowing your audience as, is really important. If you know that the parents happen to be really into their data, and they will Excel spreadsheet that stuff. Might have to come at them with that similar level of data. That knowledge is really important to saying, hey, I can communicate with you on that level. Somebody else might come at it from a very mechanical, very structured, concrete level. Then you have to really understand, oh, okay, it's because we're worried about this because you had a family member or something you love, then this happened. Let's talk that out so I can understand exactly where the friction is in this conversation. Or if they're coming at it from a, hey, I don't know, I mean, maybe this thing on social media was pretty legit. We can have a good conversation about how not everything on TikTok is true. That might also be an example of something that's not true, that there may also be an example of something that is. So I think it's these conversations around, I think knowing your audience is really important. But I don't think that this conversation structure is necessarily unique to vaccines. And what I want to emphasize is the medical establishment, we get trained to have these conversations around informed consent, around, the pluses, the pros, the cons, the alternatives. And this is the exact same structured conversation that happens with vaccination. It's similar if we consented somebody to have a joint replacement or to get an X-ray to evaluate for pneumonias. I mean, it's the same structured conversation. I think the difference with the discussion around vaccination is, wow, there's a ton of data on this stuff that is overwhelmingly supportive, showing that this is safe. And it's a real, it's sad that there's quite that this comes up as much as it does in such a contentious way. And that it has become politicized, because I haven't seen anybody politicize a knee replacement yet. No, I'm not manifesting anything out here. Right, but I think that these conversations are part of the same structured conversations that we have over all of the medical decisions that we make with our patients. Vaccination is a particularly exciting one right now, and I'm really glad that there is as much data supporting it as there is.
Well, I also think, yes, I completely agree with everything you all have said. And the extra layer of this is that when you're talking to someone about a knee replacement, they don't want to do it, or they want to do some other alternative treatment, that's just going to impact them. And for vaccinations, it's, if critical mass don't do it, it's going to impact the whole population. Now, that probably doesn't matter to many people, but, and I understand, I mean, you're doing what you think is the best thing for your child or yourself or whatever, but there are implications that go beyond that. But I don't know that saying that is necessarily to most people gonna really change their view, but as a health professional, we have to kind of acknowledge that.
Yeah.
I do think something that all of that emphasizes, though, is that in terms of figuring out how to approach this and how to support everybody who's working on this, is that this is something where there's not a one size fits all. In terms of initiatives, in terms of things that you fund, you need to be prepared. You need to be prepared to support and have materials for support activities that work on this in half a dozen different ways, depending on, so that people have the opportunity to pick and choose from toolkit depending on what it is that they have in front of them. And again, it's challenging. I play in this space all the time, so I'm really comfortable having this conversation in a million different ways. I'm a pediatrician. None of my patients have ever had a joint replacement. I've had education on how to have these conversations, but I could not possibly have that one without somebody giving me the tools to do it. And there's a lot of people for whom the shoe is on exactly the
Well, I know we're getting close to 5. I want to respect everybody's time, but since we got started a little bit late, I'm hoping we can, if it's okay, we can do another 5 or 10 minutes maybe. If there's another question right away, I have one while people are thinking. So with the ACIP implications we talked about and the potential coverage issues, and you mentioned, Dr. Dunn, about there's no kind of organization waiting in the wings to take over. I'm curious if you have an opinion, as I've heard lots of opinions over the last couple of months, about what should the approach be? Would it be better for Washington or even Snohomish to advocate for evidence-based immunization practices, or would it be better for it to be a national kind of approach where there's a national organization providing this and stepping into the buildings?
It would be better. Things always work better. I'll talk about better, and I'll talk about realistic. It's always better. Both in terms of being easier for healthcare providers, and I'm sort of including everyone in here in that. And in terms of healthcare consumers, or patients. It's always better if there's a single source of truth.
Yeah.
So that no matter where you look, you get the same answer.
Yeah.
That makes it more reliable that things are going to be done in a certain way. It makes it more reliable that people are going to feel that, oh yeah, okay, this is the appropriate thing that I should be having happen. So that would be the great thing. The great desirable thing would be for something like CIPREC, which is this organization out of Minnesota that has a bunch of ex-ACIP people, among others, who are trying to put together some of this evidence. They won't be able to do everything on that, but it would, in an ideal world, yes, there would be some national organization that would do that. Realistically, figuring out what to do with that data is probably, if things keep progressing this way and or get worse, it's probably going to fall to individual regions or individual states. I think people have asked whether something like Western states, which was supervising things during COVID, or less checking work at the CDC, whether that would be realistic. Again, it's possible. I don't know whether everybody's on board with that idea yet. Certainly, the State Department of Health has, they have expressed strong interest in at least trying to put forward, it is trying to put forward some set of, look, here's what we recommend. That people can at least follow. That won't necessarily address coverage, but I think there's a commitment in this state to at least try to make sure that if we can't get that sort of thing nationally, that at least statewide, there's some set of marching orders that everybody can look to and at least know where to go.
Anybody else have other thoughts?
I have a question. Everyone has stressed children's vaccines. Adults vaccines, I don't hear addressed as much, those going to college. And the adults who need vaccines as they approach past midlife. Since that was brought up earlier. Yeah, like me, yeah. But I don't hear that addressed, and I think there's probably different strategies that go for children and adults. One, you're talking with the children's vaccines, you're talking about parents who have the best interest of their child versus adults who may have seen things and heard things and have different life experiences, and it's impacting them. How is that approach different for you? The panel, yeah. Sorry, I'll hear about this later from Jay.
For me, when I'm looking at my patients and from different generations, I might, I do think about how to provide them information in ways that I think may be meaningful to them from just stereotyping them from a generation standpoint, right? Gen Z accepts information very differently than millennials or Gen X or our baby boomers or the silent generation. And so depending on I can infer a certain amount of information by virtue of that, right? Sorry to stereotype, but some of them work. And I find it as a place to start, right? And say, okay, this generation is likely to be very accepting of, you need to do this. Okay, so there they go. Other generations are not going to, are going to say, hey, I need you to show up authentically and prove to me that what you're doing is exactly what you would do for yourself and for your loved ones. So for those individuals, they may be more compelled by me saying, hey, this is how I thought about it. This is how I decided this. You look at this as a framework and think about how to decide that for yourself. But when I can show up authentically for these patients, I think they really receive that information better. Other individuals are very independent. they don't want, Gen X, looking at you, right? They don't necessarily, they want to come at you and with their information, they have it all set up, they're very structured about it, they may have some conclusions already. And I think it's okay to say, hey, that's fine, thank you for bringing this data. Let's talk about what's really valid and where some of this fell short, because I think I understand your overall goal.
Mhm.
And if I don't, please correct me, because that changes how we think about all of our longitudinal care going forward. So does it change how I approach the adult patient? It does, because I think the adult patients are falling into different generations and they accept information or receive information differently. And so I find that I do have to change my approach for the adult patient to say, hey, you know what? It's, HPV vaccine, it may not be as effective for the adult patient because you may have already been exposed to this. However, if your threshold for a cancer, ear, nose, and throat cancer or something like that from HPV is really, really low for whatever reason, you might say, hey, maybe this is a good conversation to be having with you. Or you have other risk factors. You're worried about your brain health, you know what, let's think about the shingles vaccine, let's think about a COVID vaccine, because long COVID does have these impacts on people's brains. So, I think it's I'm not having the conversation with the pediatric population in my practice, but I do think that there are ways to frame the conversation to broaden it that are meaningful, but you have to really know your patient. So I agree for longitudinal care.
I appreciate that. And I think that it's so important that whenever we talk about the vaccines, that we do include those adults in that too, because the adults being vaccinated does impact the children's health as well.
Right, and just the way vaccines have worked
Yes.
over history. So pertussis before vaccines used to be a disease of children and circulating children and then teenagers older, adults would be immune. But now, the people who are carrying it in the community are young adults. And they're around kids and then they get the baby sick who suffer the worst
The
consequences.
grandparents who get the
Yeah, so
vaccine,
that
yeah.
our vaccinations have changed the equations for these diseases. Yeah, keep that in mind, that adults need vaccines as well.
I would add, just one perception as to why the focus has been a lot on children as well, is that the decline is mostly measured in
Yeah,
pediatric
it is.
populations. So we should look into it. One piece of good news for older adults, we are looking at our flu vaccines, so, to the IMS and the EPI team, again, they looked at flu vaccine uptake and, kind of in line with what some of the media has been reporting from some of the polls, our flu vaccine uptake among the 60s plus is pretty stable over the past 20 years, whereas within the kids, it's just a steady decline. So, we definitely still have a lot of work to do with adults, and that's an important perspective to remember, but I do think the situation overall is a bit more urgent with the younger population too.
Yeah,
So I think some
I
of the
agree.
focus is warranted.
I just don't want to see the other.
Yes, no, agreed, yes, yeah. Definitely work to do.
I have a question. Can any of the guidelines be challenged in court if they're going against science? Is there any?
Is it challenging guidance?
You can,
I think, you can challenge anything, but
Yes.
and I don't know, this is. Guidelines are just that, they're not prescriptive, they're not requirements, they're guidelines. So again, my lay brain would think that it wouldn't be a very good legal argument, but I don't know.
Yeah.
But we may need to change, if there's gonna be a difference between like private insurance and public, a lot of people on different
Yeah.
subsidies are on Apple Health or Medicaid, if there's certain vaccinations that are no longer covered under the guidance, then we may need a state law change or a rule change.
yeah,
Yes.
Colorado, as you're probably aware, did something a little like that. They, I can provide details for people if they want, but to summarize in a rough way, they actually put through legislation that required a certain subset of things. Doing that, getting such legislation put through, especially now, is a really tall word. But that's theoretically a possible thing. you know, as a longtime colleague of mine has always cautioned, and he's an enormous public health proponent, but he's always cautioned against using the heavy club of public health indiscriminately. Because sometimes this sort of thing can produce backlash that really undermines your efforts.
Yeah.
So, yes, it's possible. The caveats are it's difficult. And it may or may not be a good idea depending on exactly what you try to do with it, I think. But depending, I think, a little bit on what happens, that may or may not be something that's to be considered.
Yeah. I wonder if there might be wrongful death lawsuits that might come up that result in the recommendations changing. That might be one way that it ends up getting challenged legally. Also, I will say many state laws refer to ACIP guidance in Washington, and so there is active. The health officers are submitting a proposal to the Washington State Medical Association to advocate for, and I know DOH is interested in as well and aware of the problem, to get ACIP specifically removed as the reference body and make it more general. So if ACIP comes back, we can go back to ACIP, but in the interim VIP or SUBRAP, we can visit them or wherever. So.
Yeah.
We did have one question online. I know we're over time, but I'll just see if we have a quick time to answer it. But there was one for Dr. Cook. Can you share more on the study, if you're familiar with it, of the Stanford, Texas study regarding the impact of increasing vaccination reductions?
Yeah, so this study just came out in one of the weeks in July, so it's very recent in the Journal of the American Medical Association there. And it was, conducted, they created models, and I'm not sophisticated enough in the research techniques of projecting disease. It's very mathematic and it's more than I'm capable of. But anyway, the authors were from a diverse group of institutions, but their conclusions, they report them with ranges of possibilities based on probabilities, right? And the numbers that I gave were kind of the median. I don't know if it was the mean or the median, but it was some middle ground of result. And it was shocking. I mean, even with, if rates stay the way they are now, it was shocking to me that they predicted there was at least a 3 in 4 chance that measles would again become endemic in this country. And the time frame they used was 25 years, which is a long time, but we're headed this is one of those things, I think, like one of Hemingway's characters said, it happened gradually, then all at once.
Yeah.
And I think that this may happen similar to that. And the same was true with the 10% reduction in vaccine rates. I think those numbers were calculated just for measles. But the worst case scenario, the 50%, was for all childhood vaccines, including polio. And I mean, that's just terrifying. But I mean, again, I don't want to inject a bunch of politics here, but I mean, we do have the highest ranking health officer in the country, that is vilifying vaccines and vilifying the CDC.
Yeah.
And so there's going to be downward pressure, and how much downward pressure is a question that no one can answer right now.
Yeah. Well, I think that was a really great way to end it. It happened gradually and then all at once. Yeah, hopefully not with the next pandemic. I think this was really great. Thank you all.
Thank you.
Yeah.
And I'm really looking forward to watching the recording and getting that shared out, assuming, we can double check with you all, make sure you're comfortable with it, but that would be great. And yeah, thank you so much.